Now I want to talk about our technique of using two tunnels to do a meniscus root repair. And it's something we've evolved in over time. When I first started doing these, we had a high volume, and I did a lot of second look MRIs on them, and it appeared that the meniscus was kind of pooching down and not being pulled down the tibial plateau and having as much ability to heal. So we developed this two-tunnel technique, trying to look at better ways to ensure that these meniscus repairs healed. So here's my disclosures. So as I've covered before, there's two basic ways to look at meniscus repairs, and the most common way is a transtibial repair. We've looked at studies looking at the difference between the strength of one and two tunnels, and there's no significant difference. The two-tunnel repair is a little bit stronger, but there really isn't any significant difference between them, which makes intuitive sense because you only have two sutures that are holding it down. The two sutures are just located in two different locations. So when we're doing a meniscus root repair, we want to make sure that our arthroscopic portals are center in the knee so that we can ensure we can get back, and then we'll go back and probe the root repair. So it's important to verify that you have a complete tear, as we've done here, and you can see where the meniscus mobilization has been performed, making sure that we've gotten down and verified. So you can see the attachment site here is completely off, and this is my scissor biter to make sure that I've completely released the tissue. Remember that a meniscus that is posterior medially extruded, if you repair it in that position, it's not going to work. It's not going to restore the normal joint contact mechanics. So the important thing is to remember to probe every meniscus root attachment every time so we're not missing these. So the next step we would do is prepare the bed. We'll use a curette to decorticate the tibia. It's important to do that. Then we'll use a Smith & Nephew root repair device. It's designed so that it can fit around the tibial eminences, and there's one that's curved to the right and to the left, so we have one that's curved to the right here. And then through this, we'll drill our tunnel. We want to make sure that these tunnels come out in the center of the decorticated area that we've already prepared. So the first step is to get the guide in, and then through this guide we'll drill a cannula with a drill, and that's what's going on right here. And then we'll take it out and then push the drill back up to make sure that we can see exactly where that cannula is going to be located. So you can see that it's in the decorticated area. And then we'll use an offset guide and drill the second cannula and drill, and then pull the drill out once we've ensured that we've got it into the correct location. So these should be about 5 millimeters apart. It's important to make sure we have them within the decorticated area of the bone. The next step is to use a first pass device and pass the suture. So it's important to make sure that we're placing the suture into good meniscus material. Ideally, because we have two separate tunnels, we have one more in the back and one a little bit more anterior to that. So I like to place the more posterior one first. And then with the cannula in place, we can pass a passing stitch up the cannula and then shuttle it out anteriorly through another cannula to make sure we don't get caught up in the fat pad. And then we'll shuttle that suture down the tibia, as you can see we're doing here. So it's important to make sure that the meniscus is able to be pulled back into a more anatomic position once we pull it down into place. We'll use a probe to make sure that we lift up the meniscus so we can get the first pass device back in. Then we'll place our second suture. I like to have the sutures in different colors, that way I know exactly where they're going to be placed. So we have the blue one usually posterior and the white one anterior. And then we'll make sure that it's within a good substance of the meniscus. So we'll pass it, pull it out, and then shuttle it through a cannula to make sure we're not caught up in the fat pad. And you can see now we're pulling up the passing wire, and then we'll pull the suture down the cannulas. So you can see it's easy to pass them when you have the cannulas in place, because passing the suture up the cannula is pretty easy. We'll use a ring grasper to grab it and then pull the meniscus down the tunnel. Once you've done that, you can make sure that your repair is in the desired location. So I'll make sure we probe it, and then after we tie it, you can see here that it's nice and firm and secure. So that's our end goal. You can see also the meniscus was a little extruded before, and we pulled it back into a more anatomic position. And I like to flex and extend the knee like this because I want to ensure that I put it in the right location. If I'm flexing and extending it, it looks like the sutures are a little tight. I probably place the meniscus repair a little bit too anterior. Rehabilitation. Afterwards, we keep them non-weight bearing for 6 weeks. We try to tie the sutures for the meniscus repair with a knee flex to 90 degrees. That way we know we can start off with early range of motion to 90. And after 2 weeks, we'll increase them to full range of motion. At the 6-week point, we'll initiate weight bearing. If the patient has some malalignment, so if they're in a lot of varus and they have a medial meniscus tear, we'll consider putting them into a medial unloader brace until the 4-month point postoperatively to maximize the healing potential. It's also important because of the cam effect of the posterior aspect of the femur on the tibia that we try not to have them do any deep squats or squatting and lifting for the first 4 months postoperatively. Our clinical outcomes we talked about earlier, most of these do very well with the right indications. So there's no real difference between medial and lateral tears, and there's no difference between those that are patients that are less than 50 and older than 50 years old. So thank you. I hope you understand now why we do a 2-tunnel repair, and we've been able to report on it with good outcomes over time.